Hello. I really appreciate everyone coming tonight and thank you for joining our webinar. And I would like to introduce our facilitator. Her name is Dr. Betsy Kamansky. She is the director of the Women's Center and Non-Traditional Student Resource Center. A little bit about her background. She has a PhD in sociology from The Ohio State. And she was also a tenure track faculty and sociology at Central Connecticut State University. And without a moment, we really appreciate everyone joining us here. And Dr. Kaminsky, thank you so much for bringing us this webinar and this collaboration between the Center for Black Studies, the Women's Center, the Department of Sociology, the Department of Black Studies, the Department of Chicano Studies. And it's just amazing. I'm so excited about this intersectional justice project that we have. And of course, everyone, I am Dr. Pattye, the director for the Center for Black Studies Research at the University of California, Santa Barbara. Welcome, everyone.
Thank you. Thank you, Sharon, and thank you everyone for joining us. I'd like to welcome you to the first webinar in a series called Intersectional Justice in California, COVID-19 Inequalities on the Front Lines. As Dr. Pattye mentioned, this is a collaboration among several departments at UCSB, and it's also supported by the Division of Social Sciences. These webinars will examine the current state of inequalities surrounding COVID-19 in California, paying close attention to how the intersections of race, gender, class, sexuality, nationality, and geography inform these inequalities. Each episode will amplify the voices of those on the front lines of the pandemic, including healthcare providers, those who work in at-risk industries, those who've lost their jobs, those without access to quality care or access to safe housing, and those who advocate for people who are incarcerated. By centering the voices of those most at risk and most adversely impacted, we hope to generate a social justice framework for responding to public health epidemics. For our first episode in this series, we're honored to have Pattye Anderson as our guest speaker tonight. As a board-certified family nurse practitioner in California, Nurse Anderson has unique insight into racial disparities in healthcare. Her public health epidemiological research focuses on addressing the cumulative impact of chemical exposures on vulnerable infants. Nurse Anderson is a bilingual alumna of USC 1994 and UCLA 2004. She's a member of the Chi Eta Phi nursing sorority and also travels with Integrative Clinics International to perform health missions in underserved island communities. In addition, Nurse Anderson promotes teen cancer awareness through the organization Positive Pounders, and she's an endurance athlete marathoner. We're extremely thankful that she has made some time to talk with us this evening and share her knowledge. So I will now turn things over to Nurse Anderson, and we'll have some time for questions following her presentation.
Thank you, Dr. Kaminsky. So I'm going to open up the screen here and get us started. Sorry. So again, thank you for having me today. I'm Pattye Anderson, and again, I'm a board-certified family nurse practitioner. My topic is on COVID-19 from an African-American nurse practitioner's perspective. And what I'm doing today is presenting on behalf of PositivePounders.com, and I'm the community service division of SlenderImage.org. And the intent of my presentation today is to create a meaningful discussion amongst community advocates and stakeholders to promote quality healthcare and improve generational clinical outcomes. To that extent, I'm going to address the inequalities on the ambulatory care frontline regarding COVID-19, and I'm going to address the 6 following questions. What are some of the challenges that Californians face today in the context of COVID-19? What are the historical continuities and discontinuities on which these challenges are built? How has COVID-19 exacerbated pre-existing inequalities? And what are the inequalities that are currently faced in California? Which populations are experiencing this crisis and to what extent? How have communities and community organizations responded to COVID-19? And finally, what resources do communities need to combat experienced inequalities? So let's jump right into this. And again, this is from my perspective as a family nurse practitioner. So what are some of the challenges that I see Californians face today? Well, starting off, I'd like to look at just the rapidly changing COVID-19 statistics and this is called the severe acute respiratory syndrome coronavirus, or SARS-CoV-2, which causes the COVID-19 disease. And as of June 29th, yesterday, there were over 5,936 deaths attributed to COVID-19, and California has some 216,000 confirmed deaths. And we see this impact across the state with areas around UC Santa Barbara having, for example, 2,872 confirmed cases and over 28 deaths, and Ventura County with 2,650 confirmed cases, and Los Angeles with this extreme number of 98,003 confirmed cases and 3,300 deaths. The numbers are really astronomical, to say the least. I looked at several websites and studies to create this presentation, and one of the statistics that I located was this California COVID by the number. And so California analyzes COVID cases by ages and genders. And you see that in the 18 to 49-year-old group in California, there were over 118,900 cases. And males are slightly outnumbering women as far as COVID cases are concerned. But what really got me interested in this presentation was looking at how COVID cases and deaths were disproportionately impacting races like the African American race, where in California, African Americans comprise about 6% of the population, but account for over 12% of COVID-related deaths. And when we compare that to white Californians who create about 37% of the population, or the Latin group that creates about 39% of the California population, we see a difference in the number of, or percentage of deaths attributed to those ethnic groups. So also I wanted to look at how California compares to the US and how California compares to the world. And so in the world, there have been over 10 million confirmed cases of COVID, and in the US, over 2.6 million cases. And here, according to this slide, over 217,000 cases. And you see the most cases are located in dense areas like Los Angeles County, Riverside County, San Diego County, and Santa Clara County. And so another question I wanted to address is, what are the historical continuities and discontinuities on which these challenges are built? So institutions, ideas, and societal problems can endure for very long periods of time, even thousands of years. And so for a long time, we in California have looked at indicators such as infant mortality to estimate a population's health. And so if we look at this graph here, we see that African Americans, at least in 2015, outnumbered other ethnicities and even far outnumbered the overall population in terms of infant mortality, or otherwise, in other words, death per 1,000 live births. And so we don't know if the health of a population in California is related to things like health insurance or education or age, or in the case of infant mortality, is it even as a result of having a multiple birth? So I wanted to continue to look at what I felt are some of the historical continuities of which this is built. So racial disparities are a complex discussion. And again, I looked at several articles and studies to create this presentation. And one by an author named Bloom influenced my graph here, which says that complex causal relationships will sustain inequality. And people of color that are born into poverty will continue to have disparities that can linger due to, for example, things like little economical trends and change in economics. And our next slides will look at that. But that is one of the possible reasons for some of the disparities that we're going to see in regards to COVID. So if everything were equal, this pie graph would have maybe 5 or 6 equal parts, but that's just not the case. And so the two largest minority groups, ethnic groups in the Los Angeles are the Hispanic or Latinx and the Black or African American groups. And how does that show up? Well, our following demographic statistics are going to illustrate the COVID-19 crisis and maybe reveal how a lack of access to health care will also magnify the results of persevering social inequalities. And I also suspect that you will see that a lack of resources will create disproportionate higher rates of infections for vulnerable populations. And these populations are the African American, Latinx, and Native American populations. So if we look at where African Americans are located, this was, again, interesting to me as an African American clinician. African Americans are primarily located in about 10 states, and California being one of the 10 states, including Texas, New York, Florida, Illinois, Louisiana. And if these names sound familiar, these are also some of the areas that many of the COVID cases were greatest. And I wanted to have a look at this, slide or some of these numbers. So African Americans by percentage of population and share of coronavirus deaths. So, for example, this shows that Black people are dying at a rate of about 2 times higher than the population. So in places like Milwaukee, where African Americans are about 26% of the population, they comprise about 76% of deaths. Or in places like Louisiana, African Americans comprise about 32% of the population and 70% of deaths. Or even in places like Michigan, where African Americans comprise about 14% of the population and 41% of deaths. So if we look at the annual crude death rate per 1,000 population, there's a formula that can calculate the total number of deaths in a calendar year divided by the estimated mid-year population multiplied by 1,000. And that's for statisticians that like to calculate numbers. So, but I wanted to look at why perhaps the health of African Americans in the US and in California is the way it is. And not just African Americans, but all people of color and people that are disproportionately impacted by diseases like COVID. And so part of morbidity and mortality status is as a result of social determinants and risk factors. And so what are particular social determinants or health inequalities that might influence disease? Well, things like poverty, racial discrimination, lack of access to healthcare is also a really large influencer on morbidity and mortality. But also risk factors like poor nutrition, physical inactivity, and high blood pressure will result in morbidity. And it is the responsibility, perhaps, of our health services, facilities, and policies to prevent and treat and be there for our populations. But again, due to conditions like lack of access to healthcare, we sometimes find ourselves in an unending and unsatisfying complex cycle of illness. So how has COVID-19 exacerbated pre-existing inequalities, and what are some of the inequalities that are currently faced in California? Well, from my perspective, I see Californians as employed, but making low wages, therefore living in poverty and oftentimes homeless. Californians are also about 11.4 million live with chronic conditions, becoming chronically ill, and in some cases depressed. And also Californians are in large part, in some estimation, disproportionately represented African Americans. And in this respect, we'll see that African American health status, poverty status, incarceration status, and professional workplace career status is disproportionately represented in my perspective. So why do I say that? Well, here in California, there are about 6% African Americans, and African American physicians comprise about 3%. So as a nurse practitioner, I professionally work similarly to physicians in that I assess and diagnose and implement a care for managing chronic conditions. And so I actually do see very few African Americans present in conferences or in situations where I am expected to represent other professionals. And so if we even look in places like the Bay Area, we'll see that African Americans comprise about 3% of the total population, but only 7% of, African Americans comprise about 7% of the total population, but only 3% of physicians. And even in the Latino or Latinx physicians, we see a very small number of physicians that are represented proportionate to the population. So even looking at white male physicians, we see that the number of white male physicians that earn under $100,000 per year is much smaller than the number of Black female physicians that earn under $100,000 per year. Likewise, white male physicians earn well over $250,000, where Black female physicians do not often earn as much as $250,000 in proportion to others. So this also shows up to me in the picture of the uninsured rate of my patients in California. So what I see are people that now have insurance and did not have insurance prior to the Affordable Care Act. So the number of people that are uninsured has gone down, but yet there are still a great number of people that are uninsured. And what does this mean? Well, it means that there are probably many people that are still making low wages. So what this graph shows is over about 40 years, people that have made very low wages have continued to earn very low wages, whereas people that have earned, let's say, above $50 have continued to earn more money over the past 40 years. And so what that shows up, how that appears is that in 2017, there were only about there were about 32% of California workers who earned less than $14 per hour. So this translates to be about 4.9 million low-wage workers. And so, of course, these low-wage workers are not insured. Also in California, what we see is that 11.4 million adults have some chronic disease. And this information I got from a health survey study, California Health Interview Study, which looked at about 5 chronic conditions, being diabetes, asthma, heart disease, high blood pressure, and serious psychological distress, and how they impacted Californians' lives. So about 40% of Californians reported having a condition like high blood pressure, which turned out to be about 7.6 million adults in California that have high blood pressure. But as their income increased, the prevalence of these chronic conditions would decrease. Many people with chronic conditions do report delaying care, and oftentimes they delayed filling their prescriptions. The cost of the insurance or lack of the insurance was often cited for a reason to avoid seeing a clinician on time or filling one's medications. I also see this in my practice as several people that come into the clinic and they have diabetes. And so about 11.6% of Californians that are 35 and older in 2012 had diabetes. And so this is also reinforced by a study by the Center for Policy Research that looked at hospital discharges in California, study done by UCLA. And it found that 31% of people 35 or older also had diabetes. And this is just another example of how the race ethnicity disparity exists in California. And so the California incarceration rates by ethnicity here shows the number of people incarcerated per 100,000 people in the African American group far exceeds other ethnic groups. So I wanted to also answer the next 2 questions, which were which populations are experiencing this crisis and to what extent. So looking at just some minority health statistics, looking at cancer, for example, in 2009, African American women were 10% less likely to have been diagnosed with breast cancer, but 40% more likely to die from breast cancer than non-Hispanic white women. And also, let me pause here. The slides that I'm reading from will be available for you on researchgate.net along with the bibliography from these slides. Okay, so other minority health statistics look like African Americans are about twice as likely as non-Hispanic white adults to have been diagnosed with diabetes by a physician. And between 2007 and 2010, the prevalence of obesity in African American women was about 53%, while it was only 32% among white women and 44% among Mexican American women. Looking at conditions like stroke, African Americans are about 60% more likely to have a stroke than white adults, and African American men are about 60% more likely to die from a stroke than white men. And if we look at the virus HIV and AIDS, we know that although African Americans comprise about 13% of the population, African Americans account for 44% of AIDS cases in 2010. So looking at the poverty by county, we can see, again, these densely colored areas in California, such as Los Angeles County, San Diego County, Orange County, Humboldt County, Mendocino. These are areas in California that have very high rates of poverty. And I want you to look at this brief video and understand the extent of the problem that Californians are experiencing. So if we look at how California compares to other states, we see that the total number of Californians experiencing homelessness is over 151,000 people, which computes to be about 26.7% of the total state is homeless. Now, this also equates to about 7,000 total family households that are homeless, and total veterans that experience homelessness is over 10,000 homeless veterans, and total people experiencing chronic homelessness was over 41,000 people. Total unaccompanied young adults between the ages of 18 to 14 that experienced homelessness was over 11,993. But this number really strikes me as exorbitant. 263,000 students from public school data reported being homeless. Also, nighttime residents in unsheltered areas, over 10,000 students. So it just shouldn't be that we have this much homelessness in California. And then here we see the number of the disparity among prison populations. Again, we have a very small number of our population that is minority, but we have a large number of the population that is incarcerated. So how have communities and community organizations responded to COVID-19? And what we know is that our governor, Governor Gavin Newsom, has enacted Executive Order N43-20 because of declaring California a state of emergency. And by doing this, he opened up telehealth services, and that has helped with addressing some of the needs of people in California. But also we have encouraged things like mask wearing, social distancing, mass testing, and contact tracing. So again, the benefits of things like this telemedicine in which Gavin Newsom has opened up for us has been things like better healthcare access, a reduced absenteeism, a great demand amongst millennials, and it's cost effective, convenient, and it does reduce the risk of infection for diseases like COVID. So that is in part why that enactment was ordered. One study that I found was by the University of California in San Francisco, which looked at how the COVID-19 pandemic and rapid implementation of telemedicine addressed challenges and opened up opportunities for new innovation. So in this study, patients had continuing needs such as reproductive health needs, eating disorder needs, general health, mental health, or addiction treatment needs. and were able to attend their medical services through telemedicine. And what this study found was that the visits increased from 0 to 97% of patient encounters through the month of March 2020. So they concluded that the COVID-19 pandemic led to widespread telemedicine implementation, and it seemed to be feasible and acceptable for patients. But what else do we recommend? We recommended things like staying home, keeping a social distance, washing hands, not touching our face, nose, mouth, covering our coughs with our tissue or arm, staying home if sick, and wearing masks, even attending things like teleconferences and meetings or telecommuting when possible. But what we found instead was that there were some people that were a little bit averse and not willing to wear masks. And even in some counties across California, we see that some people are not as willing to wear their masks. But we do, as a profession and as a society, still recommend wearing your masks inside essential businesses, when seeking health care, on public transportation. And even children over 2 who can wear their own masks are encouraged to don a mask. We encourage hand washing for 20 seconds with warm soap and water. And we also recommend social distancing. But what if you are homeless? Are there recommendations, do you think, for homeless people? Well, yes, I discovered that in the state of California, COVID-19 recommendation protocol for people experiencing homelessness did exist. And so I found it interesting, however, that if you remained in medical care, that there were different treatment protocols, of course, than if you were unsheltered. But if you are unsheltered, you should still remain practicing social distancing protocols and washing hands. But what resources were needed in order to combat inequalities that communities experience? And from my perspective, I believe that local, state, and federal level research is needed, and resources are needed, and lots of research opportunities are available through the NIH. So for those of you that are actively doing research, I encourage you to visit the NIH website. But also investments and partnerships between private corporations and government is needed from my perspective. Now, there are things like science-based and health and wellness resources that are available for communities on the NIH.gov website. Again, my references are available on researchgate.net. You can include my name, Pattye Anderson, or also you can reach me at Nurse Pattye, NURSEPATTYE @gmail.com. So now I can take some of your questions on this presentation, if there are any questions on this presentation. So I don't know if, can you hear me?
Yeah, Pattye, I'll just jump in for a second while people are maybe collecting their thoughts. And thank you for such an informative presentation with such rich data. It maybe is taking all of us a minute to digest all of that. So thank you so much for joining us. I guess one question I have, if there aren't any others, and I think Jay's going to help me monitor the Q&A in the chat, but as a healthcare provider, are there resources that you feel you could use? You mentioned research and more federal and state funding for research so that this is a research-based response. But as a healthcare provider, are there some sort of resources that you feel you need that would help you deliver the care that you give and reduce some of these health disparities that you've documented?
Things that I personally think would be needed are things for underserved neighborhoods. So what I really see a lot of are diabetics that are becoming worse now, or people that are obese that are having more issues with their obesity because of needing to stay home or feeling the need to shelter in place. And so they're not getting out. And or even my hypertensive patients, they're not getting out. And so there needs to be some sort of plan or programs to help address the needs of people with metabolic disorders. But this again is a very complex, and I'm sure that because of all the research that is being invested in this problem, that someone has probably already gotten on it, and it's just a matter of the data to be presented in a way that we can all digest it. Yeah.
I'm seeing a couple questions come in that I'm just going to read for you. It says, I'm wondering if you can speak on the connections between low rates of Black and brown physicians and COVID-19 in terms of treatment, testing, contact tracing, or even the conditions of healthcare workers that are Black, and how does COVID-19 further exacerbate their working conditions?
So let me take the second half of that question. How does COVID-19 exacerbate African American? Say that.
It talks about the conditions of healthcare workers that are Black. How does COVID-19 further exacerbate their working conditions?
Further exacerbate the working conditions.
Yeah.
Well, you know, it really, we have so many work conditions, and it hopefully is not adversely affecting their conditions. But I do know that especially at the beginning of this pandemic, we were having such a difficult time with things like masks and protective gear. So there were many people I personally know that had concerns about carrying the virus home and needing to decontaminate before getting home to carry the disease to vulnerable family members. So I would say that depending on the clinic environment, a variety of populations, not just African Americans, can experience high risks just by being at work.
Great.
What was the beginning of that question?
I'm sorry. Oops. Sorry.
That's all right.
Oh,
The
gosh.
beginning of the question was if you could speak more on the connections between low rates of Black and brown physicians.
If I could speak on the rates of low numbers of Black and brown physicians. So again, we saw those numbers of disparity where we have our minority populations, our greatest two minority populations being Hispanics and African Americans. And so it's a possibility that the low funding in public schools, particularly in African American communities, has a long-term effect on these neighborhoods that are putting out students that are going on to the healthcare careers, the science, the technology, the engineering, all those careers. So if we continue to invest in poor neighborhoods, I think we'll start to see more numbers of African Americans and Latins that are entering the medical and professional healthcare careers.
Thank you. And then moving forward, we have a question that asks, what specific data and/or research priorities do you think is needed that can guide innovative strategies to address these inequities in the pandemic?
What specific data, please?
Yes, what specific data and or research priorities can guide innovative strategies?
Well, the specific data and priorities that we should look at are the data that's coming out from places like Mayo, the Mayo Clinic, or Johns Hopkins. We have a lot of research that's going on with those entities. And so even CDC level research data that's coming out, I think if we look at that, we can start to maybe have a better idea of how to manage the disparity in healthcare. But it's a complex situation. We've been working on health disparities for a very long time, and we're hopeful, but we still have to look at ground level data. We have to look at racial data. We have to look at even data from other countries and see how their data compares to what we're seeing here.
Thank you, thank you. Next question. Could you talk more about the barriers you face as a practitioner to delivering services in this time, and how effective has telemedicine been for you?
Yeah. Barriers that I face in this time, well, I work pretty uniquely as a locum, and so many locums, and as I know it, were also called gig workers. So many gig workers like myself lost work, even working in healthcare careers. So as a gig worker, I felt the impact of the loss of work. And so what I face now and what I see now as a barrier are lack of opportunities. And that's not only because of lack of jobs that are opened right now, but sometimes it's just a matter of turnover rate. So if people are not leaving their jobs or don't need to leave their jobs, there's not a great opportunity for new employees to come in. Now also, I happen to be bilingual, so again, I'm a more unique position than some of other African-American nurse practitioners that I know, but it can be a barrier having only one language to speak, to communicate with patients. So other barriers definitely include patients that have no insurance, and you may want to see them, but if they're uninsured or cash paying, they're just not going to come in for the tests that we would like them to come in for. Or even if we want them to stay home and do telemedicine, we may have a barrier with regards to do patients have the telephones that they need to access telehealth services. So there are several barriers in addition to what my patients do not have, and in addition to things that I don't have to use with my patients. I hope that wasn't too convoluted.
No, not at all. It's obviously a complex situation. I'll read the next question. It says, how do we engage decision makers, for example, employers, to think critically about how the COVID-19 pandemic may affect their Black and African-American employees and their families? Many employers seem to just want the economy to return to how things were pre-COVID-19.
So we can encourage our employees to be diverse and to look at the current state of our nation and how things are changing for the better. So we can encourage diversity training for even our small companies or our large companies, and getting the right speaker to come in and speak on most relevant topics of how our lives show up and how we matter as a group. So we need to have diversity training in the workplace is how I see it. Mm-hmm.
Thank you.
Yes.
And next question is, I would like to know about testing sites to refer my patients to. So I believe that's a question about resources in terms of where to get testing.
Great question. So what I often will do to reduce any bias and to reduce any appearance of nepotism, I generally like to refer patients to locate the CDC recommended sites because there are so many of them that are available now. And by doing that, patients can oftentimes locate a free location. Now, if a patient is interested in paid locations, I will help identify places where they can do PCR or whichever nasal pharyngeal tests that they may want to do.
The next question is, what is the connection between one's psychological well-being and one's physical well-being? Can we reduce the risk of diabetes, obesity, etc., by improving people's self-image and psychological well-being?
Diabetes can in part be improved by improving a person's psychological well-being, but diabetes is another very complicated metabolic condition that does not solely respond to just wishing it away and feeling good and going for a brisk walk. It is a combination of things like monitoring one's dietary intake and also getting exercise and oftentimes including medications. So the problem with having chronic conditions is that it oftentimes leads to depression and anxiety or things. And so one does not oftentimes want to go out and perform activity. So it's a backwards vicious cycle. If you don't feel good, you don't go out. And if you don't go out, your condition continues to get worse. And so with the COVID virus, many people just felt really bad and didn't even do exercise in their own homes. So.
Thank you. Next question. What would be the single most important thing that you think is needed to help Black nurse practitioners provide better care to these vulnerable populations?
Well, the single one thing that I think would be useful to provide, that nurse practitioners can provide to their patients, and that can also be provided to nurse practitioners, will be more education to the nurse practitioner to deliver to the population. So if we are afforded more educational opportunities, continuous educational units through places like the CDC offering educational units, or even UC Santa Barbara offering educational units to nurse practitioners and clinicians. Again, we can disseminate that information to our populations and make a better society, make a better health outcomes.
Thank you. Next question is some follow-up to some things you've been discussing in terms of research and data collection. It says, should the government do more in the ways it gathers community health and other data and break it down with regard to race and ethnicity, et cetera? And thanks to you also for a really informative presentation.
Thank you. I do believe the government needs to do more and can do more. So I just want to say that I am an observer. I'm one of these people that I look at things and I say, why is it that way? Why is it going on? I went to the Will Rogers Beach the other day and I saw this huge truck with a comb on the back of it, and he's there combing the sand. And I'm thinking, wow, we have the resources to comb the sand on this was a Sunday morning. So we're paying somebody to go comb the sand with a great big truck and we're spending gas. But yet, do we have the resources to test the people that need to be tested and to get masks to people that actually don't have masks, or to help people that are still really in need. So we have resources, but we're not using them in the right places that they need to be utilized.
Thank you. Moving forward, can you speak on the broader mental health concerns associated with COVID-19? For instance, what do you think will be the long-term cumulative disadvantages associated with social distancing on our mental health?
Fantastic question. So long-term effect of social distancing on mental health. I get really concerned about that because I see in my practice infants now that are distanced from their own parents that are positive, or their family members, and this concerns me. So I do see that, again, we have to remain hopeful and look towards the research that's currently being generated by the numbers and by the experts. But I believe that we're going to see a dip in our numbers of depressed people, or rather, I'm sorry, a spike in our number of depressed people, and and we can probably correlate that to the poverty, the lack of insurance, and in some respect, the COVID-19 virus and its impact.
We have another thank you for the excellent presentation. And the question is, how would you reach the young millennials in adhering to wearing a mask and realizing that spread can affect the elders they live with or are around?
Well, I'm really thankful that we have avenues like Instagram, YouTube, Facebook, and I'm glad that this is being broadcast live on Facebook also. And so what we can do is use our influencers and use our young voices and to spread the word and show the data how the numbers are there, that like I showed in my slide, the 18 to 49-year-old group have the highest number of reported cases and deaths, or reported cases. So we have to stress the importance of wearing those masks, even if it's a matter of making them more fashionable and reducing costs, or innovative things that maybe our government can provide some help with. Mm-hmm.
Thank you. And then the last question we have here in the Q&A, again, thank you for this informative presentation. How can we better support health caregivers like yourself who are working with underrepresented folks?
So how you can help support us, I mean, it's great that we get things like donuts and tennis shoes, but we need more resources, and so resources sometimes actually equates to just dollars, and pouring those dollars into areas that those community-based organizations that are on the ground level, that are doing the things that help small communities, that definitely helps. And just being aware that there are problems and not turning a blind eye and assuming that the problems are going to go away with only government help, but that private investors, like many of the listeners, is needed.
This is Dr. Tediga speaking, and I just wanted to, I think it's been a great conversation and presentation. And are there any other questions? This would be the time. We have about 4 minutes left. Well, I'd like to thank everyone, Nurse Pattye, Dr. Kaminsky, Jay, Berrigan, Rosa Pinter. You've all been amazing and supportive here to ensure that COVID in California and African American nurse practitioners' perspective was a success. And I appreciate all the hard work that you've done. And what can I say? This is I'm really looking forward to this continuation of the webinars that will take place in the fall, everyone. We have different people that will be presenting on COVID in California. This has been sponsored and supported by the Division of Social Sciences. Dr. Hale and Rios have provided the resources for us to have this webinar series. And again, as I mentioned at the very beginning, I believe we have some of our collaborators on, and if they could just say something before we close, it would be, I think, Dr. Wooten, and we have Dr. Garcia, Dr. Luna, and who else am I missing? Am I missing someone? I don't want to miss anybody. So can we just hear from Jay? Is it okay if we can hear from our other collaborators, Dr. Garcia, Dr. Luna, as well as Dr. Wooten?
Hi, everybody. I'm Juanita Garcia. I'm an assistant professor in the Department of Chicana and Chicano Studies. And I just want to say thank you so much to our presenter, and want to welcome everyone to join us in the fall for the other webinars that we'll have. Thank you all for coming.
Thank you.
Hi, this is Dr. Luna. Just wanted to say thank you so much for being with us tonight for the start of this really exciting series. And intersectional justice is such a pressing issue in so many ways. And so this is a great way for us to really begin, in some cases, continue thinking about the ways that so many issues intersect and are impacting different communities in California and will continue to. So really hope that you come back and join us in fall.
But again, thank you. Thank you from the Center for Black Studies Research at the University of California, Santa Barbara, from the Women's Center, from the Department of Sociology, from the Department of Chicano Studies, and from the Department of Black Studies. Thank everyone for coming tonight. I know it's the quarter's over, but I appreciate everyone showing up for this event. Thank you and have a wonderful evening.
Thank you.